It's my distinct pleasure to join this year's Indian Heart Rhythm Society meeting, and hello to everyone from Buenos Aires Latin American Heart Rhythm Society meeting. I hope in future I can join on site. Today I will try to briefly discuss kardiyonöroablation treatment strategy in patients with Vazovagal syncope. As you know that autonomic imbalance on parasympathetic overactivity is a close relationship between carotid sinus syndrome and reflex syncope. There is no doubt about that. But we also know that in some patients with sinus bradycardia or even sinus asystole and in paroxysmal and persistent AV block, the main reason still can be parasympathetic overactivity. So if we can denervate parasympathetic system, we can eliminate some of these diseases. If you look at the pathophysiology of vasovagal syncope, as you know that after occurrence of any trigger activity, we are seeing an increase on sympathetic tone. It causes a forceful ventricular contraction and stimulates C fibers. Stimulation of C fibers may cause two different responses. In the first arm, we can see severe bradycardia or asystole due to parasympathetic overactivity, and which type is called as cardioinhibitory. In the second arm, we can see hypertension due to sympathetic withdrawal, and which is called as vasodepletion type. And great majority of patients, both sympathetic withdrawal and parasympathetic overactivity contribute to occurrence of syncope, and this type is called as mixed. So if we can eliminate parasympathetic arm, we can clearly treat cardioinhibitory type, and in some patients with mixed type. This is the very important point. According to the latest ESC guideline, Syncope guideline, if there is low blood pressure phenotype, we have only two medication, fludrocortisone and midodrine treatment. But in patients with dominant cardioinhibitory response, after severe and recurrent syncope episode despite education and lifestyle measures, we have only one option, and this is cardiac pacing. But please look at the published studies about cardiac pacing in vasovagal syncope. As you see in here, in only two studies, VPS2 and SYMPACE studies, the patients younger than 40 years old were included in the study. And at the end of follow-up period, there was no difference for syncope recurrence in both arms. So still there is no randomized controlled trial showing the positive effect or treatment effect of pacemaker in this younger population. So after that, in Q3, Spain and bioscience studies, the only patients older than 40 years old were included in the study. And in fact, if you look at here, if you use rate drop response pacemaker, you will see just a slight decrease on syncope recurrences in older population. And then in Spain and bioscience studies, authors use CLS pacing system for vasovagal syncope patient and showed a clear benefit after pacemaker implantation. As another important point, in only two positive studies showing the great effect of rate drop pacemakers and all studies for CNA, authors use tilt table testing to select potential candidates of intervention. So I can believe that tilt test has still role for patient selection in patient with vasovagal syncope. Look at the published data of CNA in patient with vasovagal syncope. In this study, very young population were selected, and in great majority of patients there was cardioinhibitory reflex syncope, and at the end of 40 months of follow-up period, syncope-free survival was more than 90% by using biatrial and spectral EGM-guided GP ablation. And then Chinese group performed left atrial approach in patient with vasovagal syncope. There was 115 cases, but surprisingly, they also included patients with mixed tip and vasodepletion reflex syncope, and they showed a similar success rate. This was very, very surprising for us. And then we published one of our series by using biatrial EGM guided approach Again, the patient population is very young, and in great majority of patients there was cardiointuitive reflex syncope, and we showed almost 95% success rate during follow-up period. But in this study, we checked the tilt test results after the CNA in the first and then the 6 month of follow-up period, and we found that despite there is no syncope recurrence during tilt testing, we can still see vasodepressor responses in our patients. So we still believe that CNA has no clear effect on pure vasodepressor reflex syncope. And then we compared CNA and conservative treatment. And as you see in here, for CNA arm, the patient was more symptomatic than conventional treatment. But at the end of the study, CNA was related 77% relative and 36% absolute risk reduction of 4-year syncopal recurrence. It was very promising result. And then we compared CNA and cardiac pacing in almost 50% of patients there was CLS pacing system, and at the end of the 1 year follow-up period, actually CNA is almost better than cardiac pacemaker to prevent reflex syncope episode. This was very important point. And then Roman Piotrowski from Poland published the first prospective randomized trial of CNA compared CNA and conventional or non-pharmacological treatment. And at the end of 2 year follow-up period, syncope occurred in only 8% in CNA arm versus 54% in control arm. It was related to very good quality of life. So this was another very promising result. And then in another randomized controlled trial, Chinese group compared left atrial and biatrial approach, and they showed that both technique has related almost 90% syncope-free survival during prospective follow-up period. In this first meta-analysis, we compared different GP method, different ablation strategies, and we found that all GP mapping methods has shown very similar success rate. But if you perform just right atrium only approach during the follow-up, you will see more syncope recurrences. So we suggest to perform biatrial or left atrial approach for vasovagal syncope cases. The second meta-analysis showed a similar result. And then last year we published the first scientific statement of CNA with endorsement of EHRA, HRS, Asia Pacific Heart Rhythm Society, and Latin American Heart Rhythm Society. I was the chair of this document, and we suggested in patients younger than 6 years old, if you think clear, reflex, recurrent, and traumatic episodes, these patients should be selected as potential candidate for CNA. And then by using tilt testing, carotid sinus massage, standing testing like cardiovascular autonomic function test, if you show the clear cardio inhibitory component like more than 3-second asystolic reflex syncope during tilt, this patient should be selected for CNA strategy. Of course, to select your patient, you can also use implantable root recorder. In patients with older than 6 years old, there are very limited data for CNA, and it's not easy to differentiate structural involvement of sinoatrial motor AV conduction system. So still pacing should be the first option. If there is mixed tip reflex syncope, at the first step, we should try a medication, especially mid-ordering treatment. But if there is still recurrent syncope episodes despite this medication, and it's the patient younger than 6 years old, CNA can be selected as a first option. This is an ongoing study comparing CNA and mid-ordering treatment, and I hope that at the end of this study, we will see the real effect of CNA. Thanks for your attention.